talking about common sports injuries and treatment. I'm a senior consultant of orthopedic surgery. My special interest is in sports and upper limb surgeries. And today I'll give you guys a quick review or introduction onto what are the common injuries that we see and how do we commonly treat them. Just a quick background. I graduated from University of Leeds. I obtained my master degrees from Royal College of Surgeons, Edinburgh, as well as NUS, and I subsequently completed my specialist training in 2018, and I finished my fellowship training in Sydney, Australia, in advanced upper limb surgery. So for those who are interested, this is our website. It's hcortho.sg. You guys can go on to have a look at what are the services that we provide, as well as any further information that you guys want to obtain, or any questions regarding any common conditions. We have also posted there as well. So me and my team, there's 3 of us, and we cover pretty much all orthopedic injuries, ranging from things like sports injuries, fractures, trauma, back pain, degenerative conditions like osteoarthritis, as well as we give a variety of not just surgical treatment, but also non-surgical treatment as well, like injections such as PRP, steroid injection, as well as hyaluronic acid. So my clinic is based in Gleneagles, as well as Mount E Novena, and we offer a one-stop service in the sense that when patients come to us, we can often obtain the same-day imaging, either X-ray, CT scan, or an MRI scan, as well as any blood test, and we can get the results back in the same day and review the patient as a review consult on the same day as well. So essentially, we can offer the patient the diagnosis on the same day, as well as tell them what are the treatment options available. So let's dive into sports injuries. So definition of a sports injury is any bodily damage that's sustained during participation, either from a competitive or non-competitive sports activity, okay? And this can affect either the soft tissue, such as the muscles, ligaments, and tendon, as well as the bone. And there are various factors that cause a sports injury. Some of the most common factors that we see are things like overtraining, lack of conditioning, if the athlete goes into the sports too fast, too frequent, if they have improper form or technique, for example, some of the weightlifters, or if they fail to warm up. I'll come to this in a bit. So there are various classifications to classify the sports injuries to different categories. But I want to bring your attention to the bottom of the graph, which separate them into acute and chronic. So acute injuries are sudden injuries, and they are usually due to a sudden high impact or trauma. This occurs when the load that is applied onto the soft tissue or the bone actually exceed the ultimate tensile strength of the structure. So in terms of muscle or ligament, you can sustain things like sprain, strain, or even a tear. And in terms of the bone, you can sustain a fracture. This is in contrast to a chronic type of injury. So chronic sports injury are usually due to repetitive stress or trauma. For example, result of any training error where usually an athlete increase their training too frequent and too high volume in a short period of time without factoring in the rest in between. And these are the conditions that we see, for example, tennis, golfer's elbow, also of tendinopathies, for example, shoulder impingement, any degenerative tears of their plantar fascia, for example, as well as things like shin splint if they run too much. So warming up is a very, very common question that we got asked. So a lot of patients come to me with sport injury there, and they're asking me, is it because I haven't warmed up enough? Is it because I'm getting old and I need to do more warm up? Well, we need to know that what is the reason that we are doing warm up. So the first reason is that we want to raise the body temperature. And when we raise the body temperature, the muscle temperature increase as well. And that actually increase the elasticity of your muscle, okay? But you want to do to a degree that it causes some sweating, but not so intense as to causing fatigue that will affect your performance in the sports that you are doing subsequently. So muscle contraction is actually a chemical reaction or chemical activity. So warming up actually enhances this chemical reaction and makes the subsequent chemical action that causes your muscle to contract more efficient. Okay, but despite warming up, injuries can still happen. So there are various studies that look at whether warming up actually prevent any injuries, and the results are quite controversial. There are some studies that show that yes, warming up does prevent any injury, but others show that there's actually no significant difference in terms of the injury rates. And there are also a lot of patients asking whether they need to do stretching and when do they need to do stretching and what type of stretching they need to do. So essentially, I will tell the patient, stretching you should only do after you have warm up. So for example, if you are doing a gym session, you should start warming up by, for example, going for a slow jog, and then only you should start to do your stretching. There are different types of stretching that one can do, but essentially the essence of stretching is that once your body is warm up and the muscle has become more elastic, you want to gradually increase the lengthening of your muscles and tendons units, and you should only do it in a very slow, relaxed, and graceful way. So there are three big groups of stretching, which are static, dynamic, and ballistic. Static means that you stretch in a very slow and gentle, and you should hold it for about 60 seconds or less. The reason we say 60 seconds or less is because there are a lot of studies that show that if you hold a stretch position for more than 60 seconds, the muscle actually goes into a bit of what we call like a spasm. So you feel a bit of discomfort, and that will actually impact your performance if you are doing very explosive training straight after. For example, if you want to attempt, like, for example, a heavy squat, then you shouldn't really be doing static stretching more than 60 seconds because that will affect your muscle explosiveness and power. Okay. The other stretching that I'll usually ask my patient to avoid is called ballistic stretching. Essentially, what this does is, for example, you sort of like stretch it to the maximum limits. For example, if you're like trying to stretch your hamstring, you sort of like bend forward and until you cannot bend further, and then you sort of like producing this bouncy movement to try to stretch it beyond its maximum limit. And that is very risky because we see a lot of injuries that is produced from this ballistic stretching. And usually only athletes, for example, gymnasts who require the extreme range of motion, extreme flexibility, should attempt to do any ballistic stretching. So when injury happens, usually it's a very disastrous occurrence, especially for some of the top level athletes. But what they should do in the immediate setting is, I'm sure a lot of you have come across, whoever has any experience in first aid, you have come across this term called the RICE, which is essentially rest, ice, compression, and elevation. So nowadays we have include the P and the D at the end. P, it means prevention. So this is when we try to prevent any further injury. And this usually means, like, for example, if they are an athlete on the field, we should stop the game and remove the player from the field. And the last, in terms of D, is like to get a diagnosis. So for example, if the injury does not settle quickly, if it looks more serious than it should, then you should actually seek a medical professional help as soon as possible, because that would change the management as well as the prognosis of the injury. What not to do initially, number one, we shouldn't apply any heat to the area of injury. So no heat treatment, no hot bath, no sauna and spa, because heat actually promote bleeding and it can cause the injury to get more swollen and further complicate the issues. Alcohol in the same vein, because alcohol actually causes vasodilation. That's why you turn red when you drink alcohol. So for example, if there's an area of injury that has already got some bleeding in the area, alcohol can actually cause more bleeding and more swelling and more damage. Same thing, try not to carry on after you sustain any injury, and try not to go for any massage, because without knowing the diagnosis of the severity of the injury, massage sometimes can actually cause things to get worse. So the most common sports injury we see in the upper limb. So I talked about upper limb before the lower limb. So for the shoulder, we see a lot of shoulder dislocation. For some of the more elderly patients, we see rotator cuff injury, impingement, etc. If it's a high energy injury, for example, cyclists, we sometimes see some clavicle fractures. In the elbow, very commonly we get tendinopathies, so tendon degeneration, such as tennis elbow, golfer's elbow. In the wrist, if it's a fall, sometimes we see a distal radius fracture. For some of the racket sports, for example, nowadays pickleball, paddle are getting quite popular. We see quite a fair amount of wrist sprain as well for those who doesn't use the proper technique when they play. Fingers, you can also get finger injury, for example, a mallet finger, which is basically injury to the last joint in your finger, as well as skier's thumb, which is basically a thumb sort of like a ligament injury or dislocation. Okay, so I first talk about shoulder dislocation is because it's one of the most commonest injury we see in the shoulder. So the shoulder is actually a very unique joint in our body. It's actually the most mobile joint in your whole body, and that's why you have so much freedom of range of motion. But because of that, it needs to have the contact surface between the actual shoulder joint, which is the humeral head, and the glenoid, which is the articulating surface. Actually, the surface that is articulating is actually very, very small. So we usually call that a golf ball on a tee, as you can see on the X-ray here. So essentially, the ball is actually balancing on a very, very, very small tee. Because of that, because it has to have so much freedom of movement, any disruption in terms of the stability, such as any tears in the ligaments, any tears in the capsule, or any tears in the rotator cuff, it can actually cause the shoulder to get a dislocation. Most of the time, 90% of the dislocation in terms of the direction is coming out from the front, so we call it an anterior dislocation. The common presentation is usually during contact sports, so we see them a lot in basketball, football. Some of the skiing injuries, we also see them, and for example, some of the racket sports, for example, badminton, volleyball. Usually the position of that cause the shoulder to dislocate is what we call the Aber position. Aber means abduction and external rotation. So usually the shoulder will pop up and coming up to the front if they are in this extreme range of motion. Usually the patient will hold their arm when it's dislocated. There you will see a squaring of the shoulder, which means that there's lost the contour of the shoulder, as you can see on the diagram here on the right shoulder. And usually they are unable to actually move the shoulder because they are in so much pain. Usually when we see a patient with a shoulder dislocation, we need to do a few investigations. First of all, we need to do an X-ray to rule out any concomitant fractures. So because fracture dislocation can happen. And then subsequently, we'll do further scans such as MRI to assess what the soft tissue injury that has happened, especially in the elderly. A lot of times they can tear their rotator cuff, and also to see how much are the loss of the bone. Usually the acute treatment for any shoulder dislocation is you want to pop it back. You want to push the shoulder back into the joint, because the longer you leave the shoulder out, the longer the cartilage will be starved of nutrition, and that can cause actually the cartilage to slowly die off, number one. And two is if it's left out for too long, you can actually cause it a lot more difficult to try to reduce it back. For example, some of the neglected shoulder dislocation that we have seen coming up after a few days or a few weeks, it's actually quite impossible for them to sort of reduce the shoulder back close. So sometimes we have to bring them to the operating theater to open up the joint to push it back in. There are various techniques of reduction that has been described in the literature to how you can sort of manipulate and reduce the shoulder back. Studies show there's no difference in success rates, but you need to know that there are different techniques actually potentially has different complications. So choose one that you actually are more familiar or more confident with. The natural history of a first-time dislocation. So shoulder dislocation might seem very benign. So for example, if a young patient who is very active below the age of 25, for example, coming with a first-time dislocation of their shoulder, it's very important that we tell them about the natural history, because this group of patients, they have a very high rate that they can get a recurrence, which means that their shoulder can actually come out again very likely, up to about 70–80%. And the problem with their shoulder coming out again is that, number one, every time the shoulder come out, it can damage further their shoulder cartilage. And this has been proven in the literature. So patients who have recurrent dislocation actually has a significantly higher proportion of getting arthritis of the shoulder later on when they go old. Therefore, usually young active patients who have a shoulder dislocation, we strongly recommend them to have a surgery to repair the soft tissue to stabilize their shoulder to prevent any further dislocation, because this can actually prevent them from getting arthritis when they go old. This is an example of an elderly gentleman who came to me with a neglected shoulder dislocation. He has dislocated more than 10 times since he was young, and now he's presenting with severe pain and stiffness of the right shoulder. And on the X-ray, you can see there's actually quite a lot of degeneration. There's no more joint space between the shoulder joint, and you can see there's quite a lot of bone spurs forming at the bottom of the shoulder joint there as well. So what we do is we do a CT scan to further delineate how much is the wear and further plan our surgery. And at the same time, we do an MRI scan to see the integrity of the rotator cuff muscles, because rotator cuff muscles are very important. If they are torn, especially in some of these elderly, then that will dictate what type of shoulder replacement we can do. So essentially, we proceed to do an anatomical shoulder replacement for this patient, and he's doing very well after the surgery. But the main point that I want to bring out in this case is that you shouldn't be needing a shoulder replacement for a patient like this. If this patient actually came to us when he was young after he has a first or second time dislocation and we stabilize the shoulder, he might not require a shoulder replacement at this age when he's actually developing arthritis. The second very common condition we see in the shoulder is a rotator cuff tear. So the rotator cuff is actually what moves the shoulder joint, and they are made out of four muscles. The most commonly injured muscles is the one at the top. As you can see here, it's called the supraspinatus. And this usually happens in the sports that involve a lot of shoulder rotation or elevation. Lateral raise is one of the exercises that we see a lot of people doing in the gym. I'll come to that later on. Rotator cuff actually tends to get degeneration as you grow old because of the overuse. And therefore, a lot of elderly, they already have a very unhealthy rotator cuff, and any sort of like sports injury can actually completely tear off the rotator cuff. Okay. So why is lateral raise a problem? We see a lot of this exercise being done either using a dumbbell or using the cables. So essentially, you need to know the anatomy of the shoulder to understand that lateral raise is actually very bad for your shoulder. Okay, so essentially, there are two muscles that sort of cause the abduction, which is the elevation of your shoulder on the side, and which is the deltoid, as well as the supraspinatus, which is one of the rotator cuff that we mentioned earlier. If you look at the diagram on the right side, the deltoid is a much bigger muscle than your supraspinatus. And they are actually having opposing effect when you do a lateral raise. So the deltoid actually wants to pull the humeral head, which is the ball, superiorly, which means that the deltoid wants to pull the ball towards the top, whereas the supraspinatus acts to stabilize the ball from going too high up, and therefore the supraspinatus is what we call a depressor. It's sort of trying to stabilize and prevent the ball from going too high up on the socket. And the problem is in the first about 30 degrees of abduction, you're mainly using the supraspinatus rather than using the deltoid. So a lot of times when patients do lateral raise because they want their shoulder to look better, to have more strength, to look more rounded, because the deltoid is what they can see and feel from the outside. There's no way they can see and feel what's happening inside in the supraspinatus. So if they're actually using a lot of their supraspinatus in the first 0 to 30 degrees, the delta actually overpower the supraspinatus to the point where you can get tears of the supraspinatus if you do it repetitively with a heavy load for a long time. Okay, so the safest way if you want to do any lateral raise is don't let your shoulder go be lower than 30 degrees because you don't want to be really using too much of your supraspinatus. If you find that you have to swing your shoulder up when you do a lateral raise and you can't gradually lower it down to 30 degrees and up again, you're definitely using a load that is too heavy for you, and you should really lower your dumbbell weight or your cable weight. So there's also this condition called the impingement. Shoulder impingement is very, very commonly asked by my patient. Shoulder impingement essentially is caused by the impingement of the supraspinatus of the rotator cuff between the two bones. And the two bones are your ball, which is sitting on the socket, as well as this bone at the top of your shoulder called the acromion, which is quite a rather flat bone. But in some of the patients, because of anatomical variance, some of the patients actually doesn't have a very flat acromion. They have what we call like a curve or a hook acromion, as you can see on the top left diagram. This sort of patient, they have a higher chance that this acromion can actually dig into their rotator cuff when they are doing shoulder elevation, and that can over time cause bursitis, which is inflammation within that space, as well as cause tears in their rotator cuff. Usually when you have a rotator cuff symptom, you have a lot of pain in the shoulder. Most of the time on the outer side, on the lateral side of the shoulder, you might have some difficulty in raising your arm overhead. And if the tear is significant, you might get a bit of weakness of the shoulder as well. Most patients cannot lie on the affected side because when they do that, they will have a lot of pain on the affected side. Essentially, what we want to do is, rather than just doing x-rays, we want to do further scans like an MRI scan to have a proper look at the rotator cuff. Once the rotator cuff tear has occurred, it will never heal. The rotator cuff will never grow back and join back onto the bone. Okay. In fact, with time, because the rotator cuff is attached to the muscles and the muscles will contract over time, what this means is that the tear size initially, if it's just a small gap, over time, as the muscle contract, the gap will actually become bigger. And this is what we call a tendon retraction. So once the tendon has retracted quite a lot, it's quite difficult for surgeons like us to try to pull it back to repair it back onto its anatomical footprint. And the second thing is, when the muscle has torn, it will gradually turn into fat because of disuse. And once a lot of the muscles has actually turned into fat, what we call the fatty infiltration, then even though we can repair it back onto the bone, the muscle will become very weak and there's a high risk of re-tearing. So the treatment for rotator cuff is basically based on the degree of the tear. So what we want to look on the MRI is we want to look at the size, the thickness of the tear. Most patients can have a trial of physiotherapy and injection first if the tear is like what we call a partial tear or very, very small size, less than 50% of the thickness of the cuff. But if you have a full thickness tear, most of the time we will advise you to go for a surgery to repair the cuff back because like I say, this cuff has been shown that they won't heal well. So how we repair a rotator cuff? So this is basically some picture that will show that how we do it. If you look at the top diagram, if you have a cuff tear, you can see usually you have a big hole in the tendon. And what we do is we use what we call suture anchor, which are essentially small absorbable screws that goes into the bone to stitch your tendon back onto the bone to allow it to heal well. And nowadays we can do it all through keyhole, which means arthroscopic. And you can see the incisions, the wounds are very small and the patient usually won't have much pain after the surgery and they can recover faster. In terms of the lower limb, there are multiple injuries that one can sustain. You can range from the hip injuries such as a hip pain impingement. They can tear their quadriceps, tear their hamstrings, or having some adductor strain if their legs are opened up all of a sudden. And you can sustain a lot of knee injuries as well. So the most common ones are definitely ACLs, meniscus tears. Some of the patients in the middle age, we also see this tennis leg, which is essentially a tear of their calf muscles, the calf gastrocnemius muscles. In the ankle, a lot of patients can get ankle sprains, Achilles tendon tear if they're not careful. And some of the stress injuries we see in the foot are things like Jones or March fracture, which are basically stress fractures of the foot bones due to repetitive stress. So for those who are into sports, if you know all these icons of football and basketball, you will know that they all have one thing in common, which is all of them have actually had a tear of their ACL and have subsequently went to proceed to have ACL reconstruction surgery done, and they've gone back into sports playing at the highest level that they were. Okay, so what is the ACL? It's a very common knee injury. ACL actually is called anterior cruciate ligament. It's a very important ligament inside the knee to stabilize the knee. And basically, it prevents translation and rotation of the knee. Okay, so most of the time, ACL tear is what we call a pivot injury. So usually it happens on the patient's standing leg when they are suddenly trying to turn direction and they felt a pop or a sudden give in their knee and they have severe pain. And if left alone, a lot of them actually have inability to actually return to play because they feel that their knee is unstable. Because like I say, this ACL actually provides a lot of restraint in terms of stability of the knee. So this is what a torn ACL looks like on the MRI scan. You can see the left is what a normal ACL looks like, and then on the right is what a ruptured ACL looks like, where we cannot see the ligament anymore. It's also very important in the MRI scan for us to look very, very carefully because when someone's tear their ACL due to the pivot type of injury, which is a rotating injury, they can actually tear their meniscus as well, which I'll come to later. Okay, so the treatment initial phase for ACL tear is to try to stop the inflammation, and this involves giving them anti-inflammatory medication, which also help with the pain and swelling, as well as physiotherapy. Bracing has some evidence on of success, depending on how bad the ACL tear is. But essentially, if the patient is young and they have got severe instability, despite trying conservative, then they have to go for a surgery to reconstruct their ACL. So this is just a video showing how ACL reconstruction surgery is done. So looking from the front, this is what a torn ACL stump look like. So you can see this whole stump here is actually not normal and it's actually torn off. And what we do is actually we have a proper evaluation, see how much of the fibers are actually left intact. Okay, so this is us using the probe to have a look at the ACL. And then subsequently, we will have the drill tunnels. This is drilling tunnel into the femur, into the thigh bone. And then after that, we also drill tunnel into the shin bone, into the tibia as well. Okay, so this is us. And then we pass the sutures up. And then these sutures will bring our new ACL graft up into the knee. And this is what a new ACL reconstruction with a new ligament looks like. And you can see that this is a very thick, solid graft that can offer the patient a lot of stability of their knee. Okay. In terms of the post-op recovery, because most of the ACL surgeries now are done keyhole, so the incisions are small. The patient can go home the same day as a day surgery if they want, or just one night stay and go home the day after. They do need quite a lot of physiotherapy to return to sport. So usually I tell the patient, even for the top level athletes, you need at least 6 months before you can return to play. And that is very important to prevent any retear of the ACL in the future. Okay, and the next is meniscus. So the meniscus are two cushions inside the knee. They act as a shock absorber. So they are found between the two ends of the articulating surface, and they absorb up to about 50% of the load in extension, which is when the knee is straight, and 85% when the knee is bent. And it provides a lot of stability to the knee. Okay, when you have a meniscus tear, there are different types of tear. So not every single type of tear actually require us to go into repair or do a surgery. It really depends on how bad the tear is. So some of the extremes ones are this on the bottom left called a bucket handle tear, which is when the whole torn surface has actually displaced into the knee, and patient can actually experience locking, which is like they will feel something jammed inside the knee, and they will definitely require a surgery to do something about it. Okay, and how we usually repair meniscus tear, similarly, we do it through keyhole, and essentially what we do is we try to stitch them back using sutures to allow them to heal so that they return the shock absorber function into their knee. So this is what the post-op wound looks like. It's very important because if we don't repair meniscus tear, there's going to be more contact stress between the two ends of the bone, and this translates to a higher incidence of arthritis for these patients if they are left alone. And the last is cartilage injury. We see a lot of cartilage injuries in the knee as well. Some of them can be due to a direct impact. So for example, if you have a sudden impact onto the knee, it can actually bruise the cartilage or tear off a flap of the cartilage. Sometimes it's due to repetitive injury. For example, some patients, they have a lot of muscle imbalance, or they have, for example, sort of like what we call knee abnormal distribution of their weight. So they might have a bit of bow leg, knock knee, and this can actually translate to wearing or ulcer of their cartilage over time if they are doing a lot of sports. And usually cartilage repair can be done through a keyhole surgery as well. So this is what a cartilage ulcer looks like. When we go inside, you can see there's a big hole in their cartilage. And what we do is we do microfracture. So we make a few small holes in the bone to promote the bone marrow to come out. And then we'll patch the whole area with what we call a scaffold to allow the cartilage to heal. Okay, so that's the end of my talk. I'll be happy to answer any questions if anyone has any burning questions. So clinically, there are a few clues that can point to us whether the patient has sustained any meniscus or cartilage injury. So for example, what we want to ask during the history is whether there was any trauma. So whether the patient has injured their knee, whether there's a twisting motion or they fall on and sudden pain or swelling inside the knee. So if there's a meniscus or cartilage tear, there's usually quite a bit of pain. You can have a bit of effusion, i.e. swelling inside the knee. And we want to know whether they have any crepitus. So like when they range their knee, do they feel like they have something clicking inside the knee, or they feel like what we call locking? So in certain range of motion, do they feel like there's something stuck inside the knee that is like mechanically blocking the motion of their knee? And when we see the patient, when we examine the patient, we can assess clinically as well whether there's any tenderness over where the meniscus and cartilage is. And then we also at the same time examine their ligaments to see whether there's any ligamentous laxity. But of course, most of the time, even though the history and the clinical examination can give us a very good idea, we still need a confirmation through imaging, which is MRI scan, to have a proper look at it. Because even though we can diagnose it, what we want to know from the MRI scan is we want to know how bad the tear is, what's the configuration of the tear, and how we can treat it, because that will change the management depending on the size, the location, as well as the severity of the meniscus and cartilage issues. Yeah. Well, there are quite a few actually. Most common sports injuries, like what I've mentioned in my talk, are basically the shoulders and the knees. Shoulders, we see a fair share of shoulder instability, shoulder dislocation, or rotator cuff issues. Whereas in the knee, we see quite a lot of ACL tear, meniscus tear, or something like a MCL tear, for depending on what sports they are doing and how they injure the knee. Yeah, but by far, like these are the more common ones that we see. So any sports that involve cutting motion, cutting as in sudden turn of direction. So things like football, basketball, badminton, even table tennis. We see quite a lot of knee injuries because when they pivot on the knee, they can actually tear off their ligaments or meniscus. For other sports like I don't know, running we see very different injuries. So runners, depending on where their site of pain is, they can develop a few things. For example, they can get plantar fasciitis at the sole of their foot. They can develop shin splints if they are running too much. They can develop tight Achilles if they are not doing enough stretching, or they can develop kneecap issues if they are running at an improper technique or they are wearing the wrong footwear or their gait is not balanced. So yeah, I mean, depend on what the sports that they are doing and whether they come in with a traumatic event, the injury can actually depends. Yeah, again, I would say it really depends on what sports they are doing. Overtraining and lack of warm-up is definitely something that we get asked a lot. But at the same time, it's very important for us to know what they are training for, what's their routine, how much and how frequent they are training. So coming from a sports background like me, I find it's easier for me to relate to what the patient is training for and whether they are actually overtraining. So this is something that we definitely have to look at when we treat the patient rather than just treating their injury itself. And because by looking at the root cause, we can actually prevent these things from happening again in the future. We see a lot of this pain at the end range of motion, i.e. deep squat. So a lot of weightlifters, a lot of powerlifters come to us and say they have pain at the knee when they are in the hole, which is like when they are in the deepest position in the squat. And invariably, there are two causes of that. One is they have a meniscus tear. So the meniscus tear is usually at the posterior horn, so behind at the back part of the meniscus. And when they are squatting, the thigh bone actually translates and go posterior and go behind, and that will squeeze on their meniscus tear at the back. So that's number one. Number two is if they have any cartilage lesion at the back of the knee. So if they have any cartilage lesion at the back of the knee, for example, a small ulcer there, when they are in the deep squat position, it can actually sort of exacerbate the pain where they have as well. So these are the two commonest knee source of pain that we see when a patient has got the pain at the deep squatting. Yeah. That is a very, very broad question. And I don't think there's an easy answer for that. I think at the end of the day, you really have to see what is the sport injury that the patient presents with, and also, with the severity of it, and what's the patient's lifestyle. Are they young? Are they old? Do they want to continue doing sports? And what's their expectation like? And I'll really tailor every treatment that I offer depending on all these factors.